Welcome everyone. My name is Ines Rio. I'm a GP and I lead the GP liaison unit at the Women's Hospital. Welcome and thank you very much for coming this evening for the first of a two-part series, which is our annual shared maternity care workshop between the collaborative hospitals. So that's Northern Health, Western Health, the Women's and Mercy Health, supported by North Western Melbourne Primary Health Network. I'd like to start off acknowledging that North Western Melbourne Primary Health Network, RW, the Royal Women's Hospital, Mercy Hospital for Women, Western Health and Northern Health would like to acknowledge the traditional custodians of the land on which our work takes place, the Wurundjeri Woi-wurrung people, the Boon-wurrung people and the Wathaurong people. We pay our respects to elders past, present and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the session with us today. So just some housekeeping. All attendees are muted. Please ask questions via the Q&A box only. You can chat away on the chat box and keep it respectful, please. That's certainly the questions in the Q&A box. The session's being recorded and you'll receive a link to the recording and a copy of the slides after the session. So a few days afterwards, we'll send you a link along with the certificate. Please ask questions without your name to be shared, and I'll ask them anonymously at the end of each of them. So we've got two sessions. Please ensure that you've joined the session tonight using the same name as the event registration or the phone number if you've dialed in. If you actually need to change the number, do just let the North Western Melbourne Primary Health staff, Melbourne staff know via the chat button. They use the list to mark off your attendance, and the certificates and the CPD can't be issued if we can't confirm your attendance. If you're not sure, as I said, if you could just pop it into the chat button. So the Shared Maternity Collaborative are the 4 hospitals, and here are some contact details. So Northern Health, contact details are here. Mercy Health. So Northern Health, Kira McGaw and Richard Sear has recently started with Northern Health. Welcome, Richard. Mercy Health's Caitlin Shaw and Sharon Tizen, which have done a lot of the background work tonight. So thank you very much for that. The Royal Women's Hospital is myself and also Emily Lawson. Hello, Emily. And Western Health is Jo Silver. So hello to Jo. And as well as thanking the people that have done so much this evening, I'd also like to thank the North Western Melbourne Primary Health Network staff, which is namely Shirfa Bahiri, who's actually running here tonight, who's here tonight to make sure everything works well, and also Vanessa Bright. So just some hospital updates. Northern Health is now sending digital discharge summaries via HealthLink. It's really important that you update your details via the National Health Services database. So if you could please do that, that would be terrific. And Northern Health's medical community virtual consult is up and running. So to hear more about that is the appropriate link. The Royal Women's Hospital, we have our public fertility care service that's now open. So that's a free service for people that are having difficulty conceiving. And if you can have the information's on our website. And tomorrow evening from 6:30 to 8 p.m, we have another webinar that goes through infertility management and also the public fertility care service. Mercy Health is also now accepting HealthLink referrals. And we all know as GPs the benefit of HealthLink referrals. You can do it directly from your desktop. It's auto-populated and you have an audit file within your practice note of what you've done. So once again on the Mercy Hospital website. So I'm moderating this evening's session. I work as a GP. I also work at the Royal Women's Hospital as a GP obstetrician and run the GP liaison unit and support shared maternity care. And I have several other roles. So our two speakers this evening are Dr. Sarah McCluskey from Western Health, who's going to be talking about the first antenatal visit, identifying and managing women at high risk. Dr. Sarah McCluskey is an obstetrics and gynaecology specialist who works at Western. She specialises in the care of pregnant women and unborn children, including looking after women's sexual and reproductive health. And also Ekaterina Zovic, who's from Northern Health, who's going to be talking about third trimester concerns. Dr. Jovic finished her fellowship at the Royal Australian and New Zealand College of Obstetricians and Gynaecologists last year after completing extensive training in Canberra and at the Women's. She's currently working as a consultant obstetrician and gynaecologist with Northern Health and chairs the caesarean section audit meetings and perinatal loss review committee. And she's been appointed as a senior lecturer at the University of Melbourne's Northern Clinical School. So thank you very much, both Sarah and Ekaterina. And I'm very much looking forward to these sessions. I'm sure I will learn a lot. So just briefly on health pathways, I keep getting things through my message. Oh, never mind. I was thinking perhaps I wasn't speaking up, but it's not that. So health pathways. Most GPs or many GPs know about health pathways, which is a really useful support tool on desktops. So they're written by GPs in conjunction with non-GP specialists and other subject matter experts. We actually have several related to maternity care on our health pathways. So you'll see obstetrics, there's a whole series here on antenatal care, the first consult, decreased fetal movements, medications in pregnancy, etc. And this is a very...
Pathways Melbourne is a collaborative online written.
We'll go to the next slide. We'll have a look at that later. And this slide is useful because it has a whole lot of resources and links that you might be able to use for both yourself and your patients.
This slide provides a list of relevant and related pathways and resources for shared maternity care, including obstetric.
For those that don't access health pathways, it's for free. And if you go to Health Pathways Melbourne, you can register and they will send you a username and a password. So over to you, Sarah, to talk about early antenatal care, identifying the high-risk pregnancy. Thank you. Sarah, I'll just get you to unmute. Thank you.
My apologies. I'll just get this one started.
Sarah, I can share mine if you're having difficulty. Would you like me to do that?
That's all right. Can you see now?
No, I can only see your beautiful face.
Oh, I'm sorry. Okay. Let me.
Do you want me to all do it?
I have completely lost Zoom. Where's it gone?
There you go. I'll popped it on instead.
Okay. So is it showing early antenatal care identifying the higher risk pregnancy?
It is. I'll just undo me. I've just shared it. I've just shared mine. Sorry about this, everyone. I've shared mine, Sarah. So
Okay.
I will try to keep up with you because I'll have to move the slide.
Okay. That's can I try that again? Is that all right? I think yeah.
I'll stop sharing.
Two. On.
I might just have to share mine, Sarah, because we can't see yours. Is that okay? Do you want to try?
Can you not see it still?
So usually there's a green button at the bottom that says share screen.
Yeah. Okay.
You usually have to have it on your desktop and then.
Yeah, it's not allowing me to. I don't know why it did before, but
Shirfa, have you given host rights to Sarah?
Yep, I have.
share.
Thank you.
So you can see my, can you see my,
Now I can see it.
yeah.
I think it's gonna work. Perfect. Thank you. Just move it to slideshow. Great. Thank you.
Okay. So slideshow.
Just at the top, in the middle.
Yeah, I know my I can't
sorry.
get rid of the Zoom screen. I can't get rid of the Zoom. Oh, there it is. There it is. My apologies. Sorry. Can everybody see now?
Yeah, that's great. Because
Fantastic. I'm so sorry. Okay. I'm so sorry. It worked before. I'm Sarah McCluskey. I'm one of the obstetricians at Joan Kerner Women's and Children. And yeah, so welcome everybody and thank you for attending. And I'll be talking about early antenatal care, identifying the higher risk pregnancy. And as those of you who conduct like care in the early antenatal period, you know that this is a really busy time and there is a lot of work to be done to lay foundations for the care for the rest of pregnancy. I just wanted to go back a little bit over the embryology and physiology of early pregnancy, just so we could all remind ourselves of what we're talking about. So I suppose just when we talk about gestational age, this harks back to, this is a convention harking back to the time when we didn't have ultrasound and we dated pregnancies based on the last normal menstrual period. And this is a convention that persists. So we talk about people as being, 6, 8 weeks gestation, but I suppose we do have to remember that the first 2 weeks of pregnancy are, we're not actually pregnant. So ovulation usually occurs around about that 14-day point, conception soon after. So just to be aware, when we talk about gestational age, we're talking about the time from the last normal menstrual period and not the age of the embryo. So the really critical time in embryology is this time between 5 and 10 weeks gestational age, when the period of organogenesis is occurring and when babies are most susceptible to teratogens which can cause birth defects. So just walking a little bit through the early pregnancy. At 3 weeks, you can see implantation of the blastocyst. At 4, you have a bilaminar and then a trilaminar disc. And if you remember all of your embryology and you think about those diagrams that show this little 3-layer disc which sort of folds and twists and turns into weird and wonderful shapes. By 5 weeks, the embryo looks a little bit like a tadpole and the brain, spine and heart have begun to form. At gestational age 6 weeks, you've got the eyes. Gestational age 7 weeks, hands, feet, mouth and face form, trachea and bronchi develop. 8 weeks, nerves are starting to branch, fingers and toes are developing. You've got the physiological herniation of the gut and rotation. Gestational age 9 weeks, baby has tiny earlobes and loses that embryonic tail. And between 9 weeks and 10 weeks is the time when we generally consider that the baby has gone from being an embryo to a fetus. And although, there is obviously still a lot of development of organs, so there's growth, differentiation, maturation of all of the organ systems, the most critical period of organogenesis occurs in these first 10 weeks of pregnancy. This is a slide from perinatology.com, which I think is really helpful for you just to appreciate the critical organ development that's happening at various different stages in the first trimester. And you can see this really critical time period between gestational age 5 and 10 weeks. And this is why early antenatal care is so important. It is a really critical stage of development for the baby. And that's just the baby. What about the mother? Well, the mother is undergoing massive physiological changes, even from very, very early on. So we know the mother will increase her cardiac output by over 40% over the course of the pregnancy. The peak is achieved in the 3rd trimester, but by 8 weeks, you've actually already got a 20% increase in your cardiac output. You've got peripheral vasodilatation, which leads to a fall in vascular resistance, and the increase in output is achieved via an increase in stroke volume and heart rate. Respiratory, there's a 40 to 50% increase in minute ventilation, mostly due to increased tidal volume. Hematological changes, there are...
Hello. Sorry.
That's right. Did you want to speak?
No, sorry.
That's right. That's right. So there's lots of hematological changes. So the plasma volume increases by 50% overall, and you also have an increase in the red cell mass, but this is disproportionate to the volume change. So you do get a dilutional anemia. You get an increase in your coagulation factors and a fall in endogenous anticoagulants. So basically, this is a pro-coagulable state, and your albumin concentrations also fall. As far as kidneys go, your glomerular filtration rate increases. Gastrointestinal side effects, so you have decreased lower esophageal pressure, delayed gastric emptying, inhibited motility of the bowels. The changes to the endocrine system are different according to trimester. So in the first trimester, you actually have an increased insulin sensitivity, but in the second and the third, you have progressive insulin resistance related to those hormones produced by the placenta, human placental lactogen, glucagon, and cortisol. Thyroid function, so HCG, which is secreted by the placenta, is structurally very similar to TSH and can have TSH-like activity. So you can actually have an increase in the free T4 and transient thyrotoxicosis with a suppressed TSH. So big changes for mother, critical period for the baby. So what does this mean for the mother? All these physiological changes do take a toll on the mother, and they will present to you obviously with reflux, hyperemesis, constipation. Many women will have low blood pressure and present with fainting. Edema is very common. They have an increased venous thromboembolic risk. Women who have pre-existing diseases, especially cardiac disease, can decompensate because of the increased demands. Also, women who have chronic diseases like diabetes in particular can respond quite badly to the physiological changes. So if you think about increasing insulin resistance in the setting of hyperemesis, maybe some gastroparesis, this is a very difficult situation for a woman with brittle diabetic control. So that these women will often need additional care in the early antenatal period. Also, the increased volume of distribution and the increased clearance of medications means that you will often need to increase medications in pregnancy to have an equivalent effect to pre-pregnancy doses. And so I suppose I brought these things up just to set you up in terms of emphasising the importance of this early antenatal period. So it's a critical period of organogenesis for the baby, time of significant physiological challenges for the mother. We talk about the developmental origin of health and disease, and this is the idea that in utero, the in utero environment programs the baby and lays the foundation for this child's health throughout its lifetime. We also know that pregnancy is a really important period for many women, and women will, more than any other time in their life, make really positive lifestyle changes, such as quitting substances, healthy diet, exercise. But we also know that it's a time of really significant stress for a lot of women, especially those who are disadvantaged, who might have mental health challenges, and for women who experience domestic violence. There is, in this first early antenatal period, we've got opportunities for interventions that really significantly improve outcomes for mothers and babies and families. And should you doubt this statement, then I suppose that these are the things that we do really automatically without even appreciating what we're doing, but they make so much difference to the outcomes for mothers and babies. So folic acid to reduce the risk of neural tube defects, iodine for normal fetal thyroid and central nervous system development, the lifestyle changes of healthy diet, exercise, healthy gestational weight gain. These will reduce the development of gestational diabetes, large for gestational age babies, and hypertensive disorders. Low-dose aspirin and calcium commenced between 12 and 16 weeks reduces the chance of hypertensive disorders and growth restriction in women who are higher risk. For women who are higher risk of premature birth, we know interventions like cervical surveillance, progesterone, and cervical cyclage will significantly reduce that risk of premature birth. Especially for women with type 1 and type 2 diabetes, improving glycemic control in the first trimester reduces the incidence of congenital abnormalities and reduces the risk of miscarriage, and also subsequently reduces the risk of future pregnancy complications. And we know that using medications with the lowest risk profile in pregnancy will reduce the chance of birth defects. I suppose one of the other things that GPs have to navigate in that in those early visits is that not all pregnancies are going to continue. So about 1 in 5 pregnancies are going to result in miscarriage. Not all pregnancies are wanted. And so termination is something that GPs do discuss with patients for socioeconomic reasons, but also for abnormalities, structural, genetic and chromosomal abnormalities. So these are really complex and sensitive discussions that GPs are having with their patients in this very early critical stage of pregnancy. So the aims of antenatal care, we all know, so we try and identify women, babies, families at higher risk of poor outcomes and use interventions that will improve the outcomes for these families. And also the idea that you optimise health in pregnancy and postpartum period to lay the best foundations possible for this mother, this family, this child for future life. Ideally, this process occurs prior to pregnancy. So unfortunately, we don't all live in an ideal world, and we know that 50% of pregnancies are planned, which means 50% are unplanned. But I do want to mention opportunistic pre-pregnancy counselling. So if as a GP you're seeing a woman of reproductive age in your clinic, ask about family planning. And I'm not suggesting that you incorporate this in the normal consultation because it is a really lengthy discussion. But if they do, say that they are thinking of planning for pregnancy, then suggest a further consultation to discuss some of these issues. So the things that, ideally we would be looking out for to optimise any current health problems. Don't forget all the routine stuff, so your cervical screen, breast check, BP, BMI, vaccinations. Think about pre-pregnancy carrier testing for genetic conditions. Talk about healthy lifestyle changes. Identify any teratogens that they might be using. So the most obvious things are the medications. So, women on Roaccutane, methotrexate, sartans, statins, all of the stuff that we, try to avoid in that first trimester. But also thinking about substances, occupational exposures. So the childcare worker is a person who's at particular risk. So varicella and CMV running through childcare centres. And you can check their vaccination status and vaccinate them appropriately to protect them in pregnancy. Psychosocial screening, obviously, for mental health issues and for domestic violence, if safe to do so. And in some women who have, very poorly controlled diseases or who have medications that you're using that are teratogenic, it may actually be appropriate for them to say, you really need to delay pregnancy until other issues have been addressed. But I suppose we don't often have the opportunity to see, in our clinic, we don't see these women for pre-pregnancy counselling very often at all. GPs would have more of an opportunity, but we know that this conversation often doesn't happen. So I think we'll just talk about early antenatal care. So early antenatal care, ideally this is provided, the first visit is prior to 10 weeks. And needs to be over a few encounters because it is a very, very busy period. There's lots of investigations, a lot of history to collect. There's a lot of really complex and sensitive discussions, and there's also a large amount of health information that you need to convey. The health pathways is an excellent framework for structuring the antenatal consultations, and it provides really good checklists so that you can make sure that you are covering all the things, because it is very easy to get a bit lost in all the details that you're expected to, of information you're supposed to collect, but also to convey. Handouts are really important. At Western Health, we use an app called Eve, and I'm sure that there are many other people using Eve and other apps that are quite useful during pregnancy. But yeah, just wanted to point out the health pathways because they are a very, very useful resource. So I've divided antenatal care, like early antenatal care, into the two parts. So the first part is about information. So gathering all the information that you need to make a risk assessment, giving the woman all the information that she needs to navigate this pregnancy safely. And then the second part is consolidating all that information, putting it all together and trying to identify the woman who is at higher risk and institute those interventions that can be useful in for the rest of pregnancy. So the obvious stuff, first visit, confirm viability, estimated due date and intentions regarding pregnancy, and identify and address those early pregnancy complications such as bleeding and nausea and vomiting. I'll chat about those just very briefly. The first visit, you really have to make sure that they're not using anything that is problematic in the first trimester. So medications, substances, don't forget the diabetic with uncontrolled hypoglycemia, environmental exposures. So, people who might use chemicals in their job, who might have exposure to radiation in their job, agricultural workers spraying, all those kind of things, and childcare workers, all of the infections that can go through a childcare centre. Perform all the routine antenatal investigations, review their obstetric history, look for risk factors for the three main things, which are premature birth, preeclampsia and IUGR. Assess their medical and surgical history and screen for mental illness and domestic violence. So with respect to bleeding and pain, I won't go into too much detail. There's an excellent framework provided on the health pathways. If a woman presents and the first thing she mentions is she's been bleeding since 6 weeks, then of course the first thing you have to do is confirm that this is make sure she's stable, and then see, is this pregnancy viable? Because the differentials are a miscarriage and ectopic pregnancy. It may just be a threatened miscarriage, but always make sure you confirm viability in these situations. So you're going to assess them to make sure they're hemodynamically stable, perform some an examination, do a speculum examination, look at the cervix, look for evidence of cervicitis, because chlamydia is a really common cause of early pregnancy bleeding, and do an STI screen because it is useful. And then investigations would be full blood examination, group and screen, and a quantitative HCG and an ultrasound. So I won't go into any more detail, but there is a really good algorithm on the health pathway. For nausea and vomiting, again, very, very good algorithm on the health pathway. Many women will say, oh, I vomit in the morning, but then after that I'm able to, eat and drink fairly normally, and I think I've got a fairly normal intake. And for those women, you talk about dietary changes, small frequent meals, avoiding triggers, things, strong smelling foods, hot foods, cooking, these are all triggers. If you're concerned that they do seem to have quite limited input, then you want to do a full ward test looking for ketones, check their blood pressure lying and sitting for a postural drop. For sort of mild vomit, hyperemesis, you can use ginger, vitamin B6, and like an esomeprazole or omeprazole, just a proton pump inhibitor to reduce acidity. If it seems to be a bit more significant, then doxylamine, promethazine at night, although they can be a bit sedating, and then metoclopramide and prochlorperazine during the day for antiemesis. And ondansetron wafers are obviously really popular because they can just pop them on under their tongue and have the antiemetic effect without swallowing them. But ondansetron also can be quite sedating during the day, and it is costly for women. It's there's a private script. For women who have more refractory nausea and vomiting, you want to investigate them. So FBE, UNEs, LFTs, thyroid function test, urine to screen for UTIs. You also want to perform an ultrasound to confirm a single live intrauterine pregnancy, because differentials would be a multiple pregnancy or potentially a molar pregnancy. That's pretty rare. So performing a forward test to assess for ketones to see if they're clinically dehydrated. And you would consider admission for hydration, B group vitamins, possibly for steroids. In this period, don't try and get them to take great big antenatal tablets. Just prioritise folic acid and iodine, because these are the most crucial things as far as organogenesis goes. Trying to get them to take a big antenatal vitamin that's got all these, all these additional extras that really they don't need at this point. They'll just tuck it back up. For my money, I would say like the iFolic from Blackmores. I have no interest, like no financial interest in Blackmores, but the iFolic, it's 500 micrograms of folic acid and 150 micrograms of iodine in a really tiny tablet, and it seems to be quite well tolerated by women who have hyperemesis. If they have a lot of, if they have a significant weight loss and they're not able to tolerate diet, then you do need to consider referral to dietitian. They might do further investigations with like calcium, magnesium phosphate, and plan refeeding. But I think that's beyond the scope of this discussion, and just the health pathways are really good to look at. Routine investigations, also on the health pathways, so blood group and screen, FB and film, urine, serology for Hep B, C, HIV, rubella and syphilis. I would routinely perform a ferritin, a TSH, and also I do hemoglobin electrophoresis on everybody in the first pregnancy. In the past, we talked about screening people only of certain ethnic origins, but the reality is that hemoglobinopathies are very widespread throughout the population, and often people aren't aware of their ethnic background, or there might be a little bit of Spanish or a little bit of something in them from 6 generations ago. So just I think anybody who is first pregnancy, hemoglobin electrophoresis, looking for those hemoglobinopathies, and then you do DNA studies as directed by your FBE and film. Some additional things to consider. If they've got a history of malabsorption, had some gastric surgery, or have dietary restrictions such as veganism or vegetarianism, B12, taking scan if they're not sure of their periods. For the women who are, who don't see GPs very often, who might have had fairly limited care prior to pregnancy, if they've never had a cervical screen, you can safely do this in pregnancy. It might cause a bit of contact bleeding. And in higher risk groups, screening for STIs like chlamydia and gonorrhea is important, because there is a higher incidence and it is associated with some morbidity. And then we move on to the information giving, which is very extensive. And as I said, you need to use checklists and handouts and apps and aids to assist with this. So talking about supplementation, talking about healthy lifestyle, food safety. There's an excellent handout on the health pathways. It's one of the women's hospital sheets, and it talks in some detail about listeria, salmonella, toxoplasma, mercury and caffeine. So it's a very good brochure for food safety and hand hygiene. Talk about CMV, parvo and varicella. You may choose to do serology for varicella and CMV at the first visit as well in certain high-risk groups. The screening tests are not routine tests, but they should be discussed with everyone. So carrier screening for genetic conditions, screening for chromosomal and structural abnormalities, and screening for increased risk of preeclampsia and growth restriction. And also some screening for risk factors for premature birth. So these are the main three: folic acid, iodine, and vitamin D. I don't get so fussed about vitamin D in the first trimester, but RANZCOG says don't give everybody 400 international units. In the first trimester, folic acid and iodine are the most important. So 500 micrograms of folic acid daily 4 weeks prior to conception and for the first 12 weeks. And if you're higher risk, then 5 milligrams daily for 4 weeks prior to conception and the first 12 weeks. And then iodine is 150 micrograms for the period of pregnancy and also for breastfeeding. Iron, treat them if they're deficient. We all know gastrointestinal side effects of iron supplementation, so discuss those with patients. We will often, for women who don't tolerate it well, we will often double the dose and give it every second day, and that does seem to reduce the gastrointestinal side effects of iron. The new iron infusion, it's not really new anymore, but carboxymaltose iron infusions are very well tolerated now, and so I think if you do have a patient who can't tolerate oral iron, who has iron deficiency anemia, low threshold for an iron infusion. Vitamin B12, so if it's a pure dietary absence, then 2.6 micrograms per day. If it's a malabsorption, you'll probably give it IM. And calcium for women who have a dietary deficiency. So 1,000 milligrams a day is quite hard to include in your regular diet. That's the equivalent of 3 serves. So that'd be like a glass of milk, a tub of yogurt, a few slices of cheese. So most women probably do require some calcium supplementation, and it does have benefits in terms of reducing the risk of hypertensive disorders and to a less extent growth problems. I won't talk too much about weight and diet and exercise in pregnancy. There's also on Health Pathways, there's an excellent fact sheet, and it talks about healthy weight gain in pregnancy. It's from the Women's Hospital. I think try not to get too hung up on BMI. Obviously, there is a great deal of variety in what is a normal BMI across different, people of different backgrounds. So you wouldn't be too concerned if you saw somebody of Pacific Island descent with a BMI of 30, but if it was a woman of Vietnamese descent, then you'd be a bit more concerned that was, an unhealthy range of BMI. So recognise the limitations of BMI and the significant variations. Talk to them about healthy diet and continuing exercise. And exercise, you really want to do 30 minutes of good exercise for 5 days of the week. So these are the handouts, but they're on the Health Pathways as well. Carrier screening. So this is not a routine test, but it should be discussed with all women. So red flags in the history include the couples who might present to you with a history of known genetic problems, a history of intellectual disability in the family, multiple pregnancy losses, stillbirths, children born with congenital abnormalities, consanguineous. These women probably would benefit from referral to genetics, because you may not know exactly what you're testing for, and it's good to have directed testing. So, and also a pre-test discussion about the implications of that. So I think in that sort of group, referral to genetics. You may be aware there is now Medicare-funded carrier screening through VCGS for, well, actually, I think it's VCGS, and there might be another test as well, I think. But basically, it's a buccal swab with a 2-week turnover, and it's testing for cystic fibrosis, spinal muscular atrophy, and Fragile X. So we know that these recessive genes are really common. 5% of Australians will carry one or more of these conditions, and 1 in 240 couples will have, matched recessive genes. So they're at risk of having a baby who is affected. So the risk overall is about a 1 in 1,000 risk per couple. So yeah, that has recently become Medicare funded. So something that you might consider. Prenatal testing. I won't go into too much detail because I know that you do, a lot on prenatal testing. Also not a routine test, but should be discussed with all women. And you're screening to detect a chance that the pregnancy is affected by a chromosomal abnormality or a neural tube defect or some other serious congenital malformation. So you need to talk to the women before the test about, you know, what happens if the test is positive, what are the implications for the pregnancy, what are my plans regarding, you know, ongoing pregnancy if I do in fact have a screen positive. So Down syndrome obviously is the most common trisomy at 1 in 400, and the risk of that will increase with age to about 1 in 100 at age 40, maternal age 40. So the two main tests that we would talk to women about in the first trimester for chromosomal and congenital abnormalities is the combined first trimester test. So it uses an algorithm that puts in maternal age, PAPA, beta HCG, nuchal translucency, and generates a risk for the various different chromosomal abnormalities. So it is a costly test for women, and a lot of women can't afford this test. It is screening and not diagnostic. Yeah, and also the results may be affected by maternal age, smoking, BMI, and IVF. So when you do a referral for this particular investigation, you want to make sure all of the details are accurate. The combined first trimester screen does have the advantage of adding some extra information about later pregnancy complications, aside from the screening for chromosomal and structural abnormalities. You'll all be aware of NIPS, so cell-free DNA, which, even though it is really sensitive with a 99% sensitivity rate, is still a diagnostic test. So, and I think the thing that we have to talk to women about is to say that even though this is a really good test for chromosomal abnormalities, it's not looking for structural abnormalities, and ultrasound is still indicated if this is what we're screening for. Performed, it's between 11 and 14 weeks, and approximately, it's performed after 10 weeks, the NIPS, and approximately 1 in 20 tests will not generate an answer, which is, and this risk is higher in multiple pregnancies. So this is a RANSCOG data about the two main screening tests. Just ignore the second trimester serum screening. So you can see the NIPS is very high sensitivity with a positive predictive value of 45, whereas the combined first trimester, a reasonable test, but not approaching 99, and the positive predictive value is up to 10%, but the NIPS is the far more sensitive of the tests. Okay. The other things that I suppose that considerations that arise from this screening test, the combined first trimester screening test, is that beta HCG and PAPA do have the levels can give us an idea about the risk of other complications later in pregnancy. So low beta HCG associated with an increased risk of IUGR, low PAPA, increased risk of preeclampsia or IUGR, and an elevated nuchal translucency is associated with increased risk of congenital, structural abnormalities, especially cardiac abnormalities. So women with an elevated nuchal translucency need a sort of a specialised 18 to 20 week scan. The other thing that I suppose we know we can screen for in the first trimester is the risk of preeclampsia. So in the past, and if you look at the health pathways, low dose aspirin plus or minus calcium is recommended on the basis of risk factors for preeclampsia. So there's high risk factors, so things like women with hypertension, with renal disease, with type 1 diabetes, who all get aspirin. And then there's moderate risk factors, so things like over the age of 40, first baby, multiple pregnancies. So 1 high risk, 2 moderate, get aspirin plus or minus calcium. So that is what is on the health pathways, but there are also other tests that are increasingly being used for screening for preeclampsia and to direct aspirin use. So the recommendations from FIGO and the Fetal Medicine Foundation are screening with a combination of placental growth factor, uterine artery Dopplers, mean arterial pressure, and maternal risk factors at 11 to 14 weeks. And then you generate a risk from this algorithm, and if it's a high risk, you commence aspirin. However, there've been quite a lot of meta-analysis that have demonstrated that actually just placental growth factor by itself can identify up to 75% of women who develop preterm preeclampsia with delivery at less than 37 weeks, and 90% of those who develop early onset preeclampsia with delivery at less than 32 weeks, with a screen positive rate of 10%. So I think the way we're probably going to move is to use placental growth factor without the uterine artery Dopplers. The uterine artery Dopplers is obviously you require a technician. It takes a lot more time. Often needs to be transvaginal. So I think placental growth factor will probably be the way to go in the future in terms of stratifying people at higher risk of preeclampsia and starting aspirin at that early gestation of 12 to 16 weeks. It is currently available. You can just add placental growth factor to your combined first trimester screen, and I think the cost is something like $50. So this is an option that some women who are at higher risk may want. And yeah, if you screen positive for this, then we would advise low-dose aspirin and calcium. Premature birth, early pregnancy, really crucial time not to miss those women who are at higher risk. And so anybody who's had a premature birth or a mid-trimester loss, who's had multiple DNCs, anyone who's had cervical surgery, so a cone biopsy or multiple LETS procedures, anyone with like uterine abnormalities like a bicornuate or didelphys, and fully dilated Caesars are also a known risk factor for premature birth, likely to do with damage to the cervix at the time of delivery. So these women, best to identify them and refer them to a cervical surveillance clinic from about 14 weeks onwards. For all women, regardless of risk, we would recommend that morphology scans should include an assessment of the cervical length. And this is something that you want to talk to a woman about, because what we recommend is that they have a less than 35 millimetre length of cervix on a transabdominal screen, that then a transvaginal scan should be performed to recheck the length. And if a woman has a transvaginal cervical length of less than 25 millimetres, then she needs to be seen in a cervical surveillance clinic and needs to have discussion about progesterone. There's also a bit of evidence about the role of omega-3 supplements. So omega-3 are these fatty acids. They form the building blocks for the developing fetal brain and retina. And the dietary sources of omega-3 are seafood and oil, but most people would have a diet that is deficient in omega-3. There's a Cochrane review that shows that there is a reduced risk of premature birth with omega-3 supplementation, but there might also be a slightly increased risk in post-dates pregnancies. So there are recommendations for supplementation, but they don't seem to have taken off. And I think a lot of the problem is that the supplements are expensive. They're an additional cost to prenatal vitamins. The prenatal vitamins that do contain omega-3 don't have enough, so they've only got 200 milligrams when the recommendation is 500 milligrams. There are concerns about the shelf life of these vitamins, and some people have advised that, if they smell a bit funny, and I think to be honest, all omega-3 supplements smell funny to me. If you've ever tried to eat fish oil, it smells pretty funny to me. So I think there is evidence that this is helpful, but we are having problems with the implementation, and it's probably a quality assurance thing related to fish oil and omega-3 supplements. So maybe just watch this space for the moment. So after the massive process of collecting all this information and conveying all this information, you need a bit of a chance for the woman and her partner to go away and kind of reflect upon all of this information, to consider some of the pros and cons of non-routine testing, to think about their preference regarding ongoing care, and to digest all the health information you've given them. And you also need to review all of the data, so all of the investigations and the history. So the second part is appropriate management of any abnormalities on routine investigations. Review of the assessment of risk. So are they high risk of GDM? Are they high risk of preeclampsia, IUGR, congenital abnormalities, premature birth? Decision making regarding non-routine tests, and plans for pregnancy care. So the Better Health Channel can give them a bit of information about having a baby in Victoria, and then referring appropriately to other services, so genetics, cervical surveillance, MFM, as required. That's the most of my talk. I was asked to say something about probiotics, and I think the review of probiotics is it does not appear there was some thought that it would reduce the risk of gestational diabetes in overweight and obese women, but it does not appear to do so. And in the trials that assessed its use, there was an increased risk of preeclampsia in obese and overweight women. So I think in the absence of an observed benefit and the possibility of harm, we wouldn't recommend the use of probiotics in pregnancy. There are also a few special cases. So we know that, I won't go into these, but you can have a look at these slides a bit later on. I can see Ina's on the screen, so I'll stop talking.
No, that's fantastic, Sarah. I've got a few series of questions, so I thought it'd be a great opportunity if that's okay. So I'm just going to, a few people would have noticed I tried to answer some because I didn't think we'd get everything there, but just a series on supplementation. And I'd like to know this one too, which is thalinic acid versus folic acid. Do you have an opinion about this? Or
No, no, I don't. But folic acid is what we use.
A few of us have got the naturopaths talking to the patient, talking to us about folic acid. So
no, I haven't been asked that one before, so I'll have to go off and research that.
We'll all have to look up that one.
Yeah.
The other thing is the question about when to avoid iodine supplementation.
Look, I don't think there's any time to avoid iodine supplementation. I must say,
I've got someone with a past history of hyperthyroidism, or if their TSH is very low in early pregnancy. You know, when you get that very low TSH and you get people that are nauseated, I often get them to stop their iodine. I'm not sure whether you do.
No, look, I would continue iodine throughout early pregnancy, just because we know that it is really important for the fetal CNS and maternal thyroid hormone production. So I think with the vomiting in pregnancy, it's often related to iron in antenatal supplements. So trying to get people to swallow big antenatal vitamins. I mean, my personal opinion is like the antenatal vitamins are overpriced and unnecessary.
There's been a bit of a comment about that and about the sort of selling of that. And I just emphasised again that the universal one is basically the folic acid, the iodine and the vitamin D.
Yeah. Sorry, I don't want to, I'm not an ambassador for Blackmores or anything like that. I have no shares, but I like personally, I found that myself when I had hyperemesis, that little tablet was easy to swallow and Elevate was impossible.
Yeah. And then there's a comment about sort of fish oil and omega-3. Says, I also have an issue of fish oil from a sustainability point of view, from an environmental sustainability point of view. And I think that we need to consider that in our consultation. So that one's done. Good question here, great question here about if somebody has got is high risk for preeclampsia because of an existing condition such as hypertension, but you find that they're low risk on screening, would you still give them aspirin?
Look, I sometimes think, would I take the aspirin myself? And I think, yes, I would.
Yeah, I was thinking, that's a low cost intervention. With
it is a low cost intervention. Yeah. And look, I suppose if you have a woman who tolerates it well, who doesn't have any, reflux, who doesn't have any, is not hypersensitive, doesn't have sort of an asthma type reaction, I know aspirin does increase the risk of bleeding and bruising, and you can have GI bleeds, and it's not a harmless drug. I don't want to discount the complications from aspirin, but I there is a lot of, like, I suppose there is a lot coming out about placental growth factor being an indicator of placental health. And it is, like, I'm sure Ekaterina will talk about placental growth factor and SFLIT in terms of placental health later on and helping to determine timing of delivery. But placental growth factor is basically produced by that syncytia trophoblast. It's a vasogenic growth factor, so it encourages angiogenesis. And generally speaking, it is a really good tool for determining the placenta that's well perfused.
That's right.
Yeah.
And the question, look, now you might have answered this because I was answering some questions, but when do you start low dose aspirin? And I'm not sure if you mentioned, Sarah, that it's
about 12 weeks.
Yeah, best taken
12 to
at night
16.
too. Did you mention that? It's best
No,
taken
no.
at night? And
But you're right.
Yeah.
So the best time is, best time is at night. Yeah.
And there's a randomized control study into that, so that's interesting. And I usually just say 100 milligrams because it's easier to take, because if you do the 150, you have to throw the other bit out. So it's just a practicality from a GP point of view. And the other question that I'm still confused about after all these years is, what's the place of calcium supplementation? Did you answer that before?
Yeah, so calcium supplementation, if a person is deficient in calcium, and many women are, then there is a benefit to calcium supplementation in terms of reducing the risk of preeclampsia. There does, like, I kind of was going on my happier way going, calcium, very little harm. And then I got a call from a urologist for a woman who had like renal calcula, and the urologist blamed it on the calcium supplementation. But look, I think you can look at the dietary sources, and look, some women do have very good calcium, dietary calcium. I think for women who might not eat any dairy, then I think calcium supplementation is reasonable and seems to be low risk and does
go through a few more. The good old vitamin D, anti-D, if there's bleeding in early pregnancy, and so when do you give vitamin D? So my take-home message is, if it's threatened but it's an ongoing, then you don't worry about it.
Before 12 weeks, before 12 weeks,
as long as you're sure of the dates.
But
if it's if there's an intervention other than medical termination of pregnancy before 9 weeks, when you don't have to give it, but if there's any other sort of intervention even before 9 weeks, you give it. Is that what you go by?
Yeah. So beyond 12 weeks, if there's bleeding, I would give. Before 12 weeks, if there's a instrumentation of the uterus for like a suction because of a miscarriage or an ectopic pregnancy, then anti-D. Yes.
Now, I've got another good question, which we're increasingly getting in general practice, which is the very sensitive ultrasound early on that tells us you've got a subchorionic hematoma, and that seems to be increasingly reported, and often saying, this is the size of it. What do we do in that circumstance when it's an incidental finding?
I think it's really, it is really difficult because our ultrasounds are so sensitive, and they do increasingly pick up stuff that we almost wish we didn't know about, because there's nothing you can do about it. So I think you just sort of make sure when you send them for their 20-week scan, that you send them to it depends on the size. If you've got a really sizable subchorionic hemorrhage, then you maybe want to send them to somebody who is like a COBU scanner. Otherwise, just look for it again at the 20-week point and then direct your future pregnancy care based on that.
So my question really, so again, from a GP point of view, is, do I tell people to just take it easy, take 2 or 3 weeks off work and then do it again? Is there any evidence for that? Because that's really what it gets down to. No,
I think it's like most early pregnancy sort of events, it's kind of, unless it's like, like obviously preterm labour or cervical incompetence, that's a different etiology. It's rest. None of those things are shown to make any difference. Yeah.
So I'm going to ask the last 3.
Although I do think it's worth saying that even though if they have intercourse, often that will provoke a bleed. So even though they're not going to do any harm by having intercourse, it can increase anxiety. So I think sometimes if a woman does have a reasonable size subchorionic hematoma, you can say to her, look, you know, you're not going to do any harm to the pregnancy by having intercourse, but you may find that you bleed afterwards, and that is going to be, you know, that can provoke anxiety, and then you might want another scan just to make sure everything's all right. So yeah.
Okay. The good old CMV question.
Yeah.
Do you do CMV serology the first, you know, is there any point doing it? When would you do it?
Look, there are some cases where I might, like, if the thing is, like, your primary CMV infection is the one where you're more likely to get those congenital changes, and, you know, CMV, one of the leading causes of deafness, like congenital CMV, one of the leading causes of deafness, and like there is an intervention that they can make postnatally. So, you know, you can use what is it? Is it polycyclic? Anyway, there is proven benefit of that to reducing the sequelae. I think if I were a childcare worker, I would like to know that I had previously been exposed to CMV. So I think, like, in women who are really high risk, who are, you know, working with young children, I think for my, like, in my personal case, I would like to know my CMV status. For other women, I think just the general advice that, you know, we should be giving to everyone, like, you know, don't clean your child's dummy by putting it in your mouth. Don't share cutlery with your.
I think so, and that's been shown. And Lisa, we've got Lisa here next week.
Yeah.
And you know, those interventions of washing your hands, not sharing food, all of those things actually have been shown to decrease it. So it's the preventative measures, I think, that are more important than that. And also, I think responding if you think somebody has clinically got a rash or an infection, then doing it.
Yeah. Don't eat your toddler's leftovers.
Yeah, I'm just going to ask one more and then stop on a very controversial one, which is the question about, and I find this too, is we have that sort of 5% of people carry the, you know, CF gene or whatever it might be.
Yeah.
However, is that in that sort of typical Anglo-Celtic? Are we taking that population when we really don't have, like, often I've got a population of women that come from Africa or Southeast Asia, and yet we're giving them the same information. I'm not sure about whether that's very accurate.
Well, I suppose the like, we're talking about couples, and I think ethnicity is becoming more and more, like, you know, we're more and more of a melting pot. Like, it's very, you know.
I think you're right, but I do think that, you know, the point is that the figures are probably inaccurate.
Yeah, I think also. I think also the other thing you have to think about is it's not just cystic fibrosis. You're also talking about SMA, which is an awful disease. Like, you know, part of the reason this has become Medicare funded is because I think it's like Mackenzie's mission. So, like, a little girl who died prior to the age of 1 with type 1 SMA. So, and you know, knowing that. Yeah, like,
and so as we said, it's, you know, rebatable from the 1st of November this year.
Yeah, so
pregnancy, so that'll be valuable. And I know quite a few of the labs have got no out of pocket for it as well. So let's hope that lasts.
Yeah,
it's better to do pre-pregnancy.
The other thing I wanted to talk about, which was raised at there was a global obstetric update run by Mercy last week. There was some interesting talk about endocrine disruptors and soy products, and whether or not, because we are seeing an increasing number of things like hyposphalias, and it's thought to be related to environmental endocrine disruptors. So BPAs and, you know, all of the
and there's good old, I always tell people, you know, no plastic in the microwave, the BPA sort of aspects of it. So I always think that, you know, decreasing pesticide and that sort of use of, you know, but apparently also soy milk is a high risk of like it does carry an equivalent kind of risk. So I don't know, like, I feel like we really run the risk of overwhelming pregnant women with all the things that we ask them to do, like GPs in the provision of this advice too.
I to be honest, I don't know, like, how people cover it. It is a ridiculous amount of information that you're expected to convey, and I think we really need to look at the way we give information to people, because it is
overwhelming.
It's overwhelming. It's very.
And there's also a conversation to be had about, you know, allowing people to enjoy a beautiful time of their life, rather than making it pathologizing everything too. And that's, you know, that's the art of our medicine. Now I'm going to finish on this because I'm not sure if you read The Age this morning about progesterone and about the lack of evidence going into guidelines. So, but if you haven't, it's worth reading The Age today.
Okay, I will go and review it.
Yes. So the question really is about recurrent miscarriages, and the question is really about when to start progesterone. But I think that the bigger question is I'm not sure that we're really sure about the evidence around progesterone and miscarriages, but when would you consider starting it for somebody with recurrent miscarriages?
Look, I suppose in the setting of like it's often used in IVF for like, luteal phase support. So for recurrent miscarriages, I would have to go back and review the evidence. I know, like when we talk about preterm birth and we talk about mid-trimester losses and cervical incompetence, then we're often starting progesterone at about 16 weeks. But look, for recurrent miscarriages, I have not reviewed that evidence, and can't
I think it's probably a bit of a live discussion, and certainly I think that people are giving progesterone in the thought that, perhaps it's not too harmful and you may as well try something, because when you're often put in that position of thinking, poor woman and couple, what can I offer them? So I think that, different people, different providers have probably different thresholds depending on how anxious the woman is and that shared decision making. But Sarah, that's fantastic. I've learned so much. Thank you very much. And Ekaterina, over to you now. Thank you.
Hi. Thank you, everyone. Fantastic talk. Let me just find my slides. And I might just quickly say about the recurrent miscarriage, what we do at Northern, we do start them on progesterone if they have a bleeding. So in fact, we will supply them with a script to say if we were first bleeding in the first trimester, we will start on the high dose of 400 twice a day, following the NICE guideline, we will hope. But it will help. And we continue until 15 weeks. That's by NICE guideline.
Thanks.
Okay. But in terms of, I have a very wide topic, problems in the third trimester, and I thought I'll keep it interesting. And first of all, of course, I have to talk about hypoglycemia in pregnancy, or basically too much sugar. It's a global health problem. 1 in 6 of our births occur to a woman with some degree of hypoglycemia in pregnancy, and 84% will be due to gestational diabetes. And of course, as you're all aware, diabetes and obesity is a real pandemic. Even after we live through COVID, the numbers of type 2 diabetes is tripling worldwide over the last 30 years. And we do think what the diabetes has this programming or imprinting during the pregnancy, and diagnosis and management might help turn the tide of the diabetes around. And so even Time had this kind of a big topic, so talking about what about fetal pre-programming. And we know that both actually being malnourished and being fetally growth restricted will cause a future risk of a type 2 diabetes, impaired glucose tolerance and hypertension, as well if you born macrosomic. So it's kind of best to be somewhere in the middle. And if we think about diabetes and adverse outcome, we always look for evidence. Is it really that bad? And we do have a good evidence. The HAPA trial, which was published in 2008, it was amazing undertaking. Over 24,000 people were involved in the study. And they did show that there's a significant correlation between diabetes and large for gestational age and primary cesarean section and clinical hypoglycemia in the newborns, as well as other things like combined outcome, shoulder dystocia, NICU admission, maternal injuries. But they also follow up the study and look if there's any correlation with maternal glycemia and childhood glucose metabolism. And there was definitely a connection between that, as well as the sequence of adiposity. So we do know that diabetes is not great, but the question is, can we really change it around? And can lifestyle modification prevent the diabetes if we started in early pregnancy? So there's a few reviews, and one of them, a Cochrane review, was published in 2012. Then they concluded that exercise program actually has no clear effect in preventing diabetes. But then the other randomized controlled trials showed that the physical activity intervention didn't reduce the risk of healthy pregnant women developing diabetes, but reduces the maternal weight gain and risk of cesarean section and LGA. And then the other question people will ask me, should you try low glycemic diet? Should we put every pregnant woman And again, there's quite a few studies looking into it. And one of the systemic review showed with low glycemic diet will reduce risk of LGA baby, and any dietary contribution was effective in reducing the incidence of diabetes compared to the standard care. However, the following study showed doesn't really reduce the high birth weight babies, but has some beneficial effect on maternal gain and glucose tolerance. And then they will combine intervention, then they'll look at both exercise and the diet. And again, the results are a bit inconsistent. Some results will be very positive and other will have no finding. So current evidence recommendations should, what we should advise women that physical activity and healthy eating during pregnancy will help to reduce the excessive weight gain, but do not appear directly reduce risk of diabetes in pregnancy. In terms of a diagnosis of diabetes, and I'm sure you all know, that's how I think you will come across it too, because you probably received the result before us, especially if we order between 24 and 28 and see our patient shake at about 28 weeks. And there was a big discussion when ADIPS really provide their guidelines, because they say, look, we're going to pick up so many women with diabetes. How are we going to manage the tide of the gestational diabetes? We'll need extra high-risk clinic, extra endocrinologist. We'll have more ultrasounds, more inductions. But actually then they did all the modeling and say, no, I think long-term it will be still very effective. So that's how we stuck with our guidelines. But I just want to remind you about if you see very, very high fasting above 7 or very high 2-hour mark above 11.1, you're probably looking at diabetes mellitus in pregnancy. And this woman will be more interested in seeing in our high-risk pregnancy quickly and seeing them with our endocrinology doctors. In terms of other testing, and I saw it in the chat, the people was asking, what about HbA1c in early trimester? In general, we don't know enough around HbA1c. We do know if it's 6.5 and above in non-pregnant women, it's suggestive of a type 2 diabetes. We have a little bit of data from New Zealand, because actually there they use HbA1c as a kind of a screening test in early pregnancy. And one of the big studies, about 16,000 people, show with HbA1c above 5.9, definitely associated with adverse outcome, but there are no worldwide recommendation. I certainly will still order HbA1c for women who can't tolerate glucose tolerance test due to the nausea, hyperemesis, gastric surgery, or purely they don't want to do it. But in my high-risk group clinic patient, I will give them glucometer for 2 weeks to do their BSL monitoring. That's how I would think about picking up diabetes. And I just always remind you, I'm sure you're very familiar with National Diabetes Services Scheme. It's an amazing resources. And thanks to COVID, actually, it's a very quick registration process. A patient will register online. They will receive their membership number, usually while they're still talking to you by text or by email. They can access the glucometer from local chemists, which is a really big shift, so they don't need to travel to the hospital. We still store them too. They have access to subsidized glucose testing strips. There's education, video, reading material. If they need the insulin needles, there will be free access. And there's also benefits after pregnancy, because let's face it, most of us forget about gestational diabetes 10, 20 years down the track. But NDSS will actually send a reminder to the patient. And also there's a special program with kind of social platforms, so it makes it a bit more interesting for the patient to be part of it. And of course, there's a benefits for all of us, because we can collect national statistic on prevalence of diabetes, and also how many women will actually require insulin in their pregnancy, because they're the higher risk group. And the biggest question is always treat or not to treat. And do we have evidence that treatment of gestational diabetes actually improved the outcome? And yes, we do have evidence, and most of us will really talk about our choice and the London trials. And I just briefly put it in and saying, but if we treat the diabetes, we will reduce from about 4% to 1%. And number need to treat is not too bad at about 34. But out of interest, that you can see that there's a different targets for both studies. So we look at slightly higher targets of 5.5 fasting and less than 7 postprandial and a choice. And then London's had a bit lower standards, less than 5.3 and less than 6.7. So, and it's something we accept, but this is actually different glycemic targets, and not just different across the states, they're actually different within a state across different clinical centers. So you might see the patient who visited Royal Women or Northern, which has the same standards. And then you'll see someone from Mercy who have slightly higher targets. So it's okay. And I also find it, if my patient will research and come to me and say, this is the targets I would like to follow, I usually say that's fine. But I really would like you to stick to these targets. And in general, we say about 40% of our patients who will diagnose with the gestational diabetes in the third trimester will require some kind of pharmacological treatment. And the most commonly, you will see our patient on insulins. And we will think about starting insulin if they have a free high reading fasting and free high reading postprandial. And we obviously try all our modifications already. In terms of insulin, it's simple. You will see them on Novorapid, Humalog, Protofen, or Optisolin. But sometimes patient will ask, the patient will ask me, and GPs will ask me, what about metformin? Can we use it? Is it used? The biggest concern was around metformin, but it does cross the placenta, but it's really safe in pregnancy. The reason why I wouldn't advise metformin as a first agent most of the time is because the studies suggested that most women will still need an additional insulin on metformin. However, we have enough evidence to say that it is safe. So there was a MIG trial, which is just at the side of the screen, and they follow up their babies at 2 years of age and at 7 and 9 years of age. They did notice that the babies from metformin group were a little bit a higher body mass index and slightly higher waist circumference, especially in the Auckland group. But again, this mothers of these babies were also bigger. So kind of not surprising finding, again, talking about pre-programming. But how does patient think when we talk to them about diabetes? They often find it very confusing, very disappointed, very concerned. They don't understand why, because a lot of our patients actually who are diagnosed with diabetes, they're normal, slim, they don't have a significant family history, they do eat vegetables, and they're very rarely positive about this diagnosis. But every time I will counsel my patient about gestational diabetes, and I have a disclosure, I had gestational diabetes myself in the second pregnancy, I always say it was my probably healthiest me ever, because this is really your opportunity to change it around, to make it your problem, to make it your journey. There's lots of support. There's more visits for you. There's extra monitoring in place. And we know that the treatment will improve outcome. And if you do the things right, we actually have a chance to reduce the risk of type 2 diabetes in the future. So I always try to stay positive about this negative diagnosis. In terms of what we do, just very briefly when we diagnose it, and again, it will be a little bit different because there's no consensus worldwide. What should we do about and the timing of delivery and how often do we need to scan the woman? But generally, we do give them targets, and most women will bring their books to your visits and show you what's their targets. But if we have a GDM diet, we will consider the one ultrasound about 36 weeks. We will hope with everything looking really good and with good control, allow us to treat it as a low-risk pregnancy and looking at induction about 40 weeks usually. We were gestational diabetes of insulin, and again, in Northern Hospital, we usually do 3 growth scans around 28, 32, and 36 weeks. And again, we encourage, if we have a good control, no other risk factors, we probably looking at more time in this pregnancy and induction about 39 to 40 weeks. However, the poor control, macrosomia, large amount of insulin or other risk factors, we're looking at having baby around 38 to 39 weeks. And we don't know if we're thinking about macrosomia in pregnancy, we're thinking about delivery via cesarean section, even though we know we need to do 443 cesarean section to prevent one permanent brachial plexus injury. So but that's something we will discuss in antenatal clinic. And very important, when postpartum happens, we're really happy because we just write a slip for GTT and we say, we'll see you in a couple of years. But I know for you guys, the work just will started. Remember, the 30% of this woman will come back with gestational diabetes in the future pregnancy. And we say about 1.5 to 10% per year will develop type 2 diabetes, which is roughly about 60% of our patients in 10 to 20 years. So we say annual OGTT if we're contemplating another pregnancy, and if not planning future pregnancy by high risk every 3 years, OGTT, low risk, they say you can do fasting sugar or HbA1c every couple of years. Saying this, in reality, very rarely women will commit to another OGTT. And I know this is a DIPS recommendation, but I will just say even yearly or 2 yearly HbA1c probably will be pretty good option. And obviously, a nice flaw from gestational diabetes would be to talk about the macrosomia. And the problem with macrosomia is we don't have a standardized definition. What is a large for gestational age? Traditionally, we thought it's about 90%, which is about 4 kilogram a term. And then there might be some people say, no, we should go with 95, which is about 4.5 kilogram a term. Another group say maybe 99, because that's when the real complication starts above 5 kilogram. And again, another reminder, we are much better at picking up small for gestational age than large for gestational age. And is that an issue to be macrosomic baby? Yes, absolutely. We know that being macrosomic will significantly increase the risk of shoulder dystocia, and it will stay about 14% between 4.5 to 4.7 kilograms, and will be 21% if you're 4.7 to about 5 kilograms. And it will cause about, if we need a mid-cavity delivery, about 50% risk. And I broke down all the brachial plexus injury for you if you would like to look at the numbers. But obviously the other risk is hypoxia and skull fracture and fetal injury and neonatal hypoglycemia. But also maternal, if we think about macrosomia, it will increase risk of women needing instrumental birth. If it's more than 4.5 kilogram, about 20% will, and about 45% women will have an emergency cesarean section. And of course, genital trauma and PPH. So are all about thinking about prevention, can be prevented. So one of the mechanisms they're talking about, can we stop pregnant women being obese? Is the bariatric surgery an answer? And initially we had the really high hopes until we had this Sweden study in 2015, which called Outcome of Pregnancy After Bariatric Surgery. And it clearly shows that, yes, you will reduce your diabetes, you will reduce your LGA significantly, you will halve it. You will shorten a little bit your gestational age for about 5 days, but you will double your risk of a small for gestational age, and you will significantly increase your perinatal mortality. And that explains why all our patients after bariatric surgery is considered to be high-risk pregnancy. A bariatric surgery was done within the last 2 years. That's why we like to see them in our high-risk pregnancy, because the risk of small for gestational age baby. Other intervention is to stop women become more obese than they're pregnant. And again, this is your health pathways in place. It's all about education, about appropriate weight gain. At Northern, we're a bit of an old school. We weigh our women every appointment. And we do talk about the weight gain, and we remind them that in a high BMI group, we like only about 220 gram gain per week. So, it's not as strict as in Russia where you're from. We don't put them on a diet, but still. And in terms of the secondary preventions, it's all about identifying our LGA baby correctly. And the problem lies is how good we are at really figuring out who is LGA. So fundal height measurement will identify about 1/3 of your big babies, and ultrasound will give you mistake about 10 to 15%. And again, we're much better scanning small baby than big baby. We say it's about 50% detection rate of birth weight above 4 kilogram with positive predictive value 50%. But if we do find our baby being LGA, what do we do as obstetrician? We often will talk to them about things like elective cesarean section, or more commonly induction. With elective cesarean section is usually people who has a diabetes, and estimated fetal weight will be more than 4.5 kilogram a term. Or for women without diabetes, we say if we're estimating above 5 kilogram there's a little bit of quite a bit of evidence actually around the induction of labor at 39 weeks, and I put them in brackets in case you want to have a look at the studies. But most hospital doesn't have a protocol around induction for macrosomia. However, we certainly will consider it and discuss it with our patient. The only other thing I was thinking, one of the good numbers to remember, which is easy to remember, is because commonly we do ultrasound about 36 weeks. And if at 36 weeks, your baby is about 3.6 kilograms, there's a good correlation with a risk of a short dystocia. So 36, 3.6. And obviously, nicely flowing from here is a small for gestational age. And one of the most wonderful talkers is Sue Walker. She talks about it. And one of the most catching phrases she uses, if you are born small, you keep dying all your life. So it brings it back to the idea again of being small puts you at high risk of a stillbirth, at the death in the first year of life, at handicap, and have a hypertension, having a coronary problem and type 2 diabetes later in your life as adults. So it is a big deal because as we can see, small for gestational age will increase the stillbirth rate by about 3 to 4 folds. Over half of the 3 million stillbirths yearly are growth restricted. So we do think if we improve our detection rate of a small for gestational age baby, then we'll probably recognize this. We will reduce the risk of stillbirth and late pregnancy. But despite that, more than 70%, 75% remain undetected before birth. And there's a lovely graph, which is sometimes I show the patients as well when they ask me, why is that important? And it shows that all pregnancy has this background risk of a stillbirth, which will increase after 39 weeks. That's why if you attend obstetric conferences, they will always talk a little bit about induction for 39 week. But this graph looks very different. You can see it's much higher risk for the 37 week for them small for gestational age, and the risk will increase after 37 week. So a fetal growth restriction and a small for gestational age, is it the same? Yes, but it is different. It's not a synonym. And a growth restriction imply pathological restriction of genetically and genetic growth potential. So this baby is supposed to be bigger, but due to placental insufficiency will slow down in that growth. Some, but not all growth restricted fetuses are small for gestational age. So sometimes you will see these babies who started at 90th centile and then end up at 20th, which is technically they're not small for gestational age, but they're definitely fetally growth restricted. And about 50 and 70% of your small for gestational age fetuses are actually constitutionally small, and their fetal growth actually appropriate for their maternal ethnicity and maternal body mass. And we know the likelihood of fetal growth restriction is higher if you have a severely a small baby on the measurements. But to differentiate, we do need to have accurate measurements, and we do need a functional assessment. So that's when we're talking about our checking the fluid around the baby, checking the Dopplers, and we do an extra monitoring with the CTGs. The question is, how good is a measuring tape? And that's my favorite question to my medical students. I let them guess, and the sensitivity is about 20%. And overweight and obese woman sensitivity is about 13%. We have a positive predictive value 18. But we know we can increase our sensitivity a little bit. So if we do measuring tape by the same person, and if we plot it in our customized fundal height chart, we're much more likely to pick up the small for gestational age. And if you do your fundal height measurement in centimeters and it's deviates by 3 or more centimeters from the gestational age in weeks, or if it's plateaus across your measurements, please organize the growth ultrasound for this patient, and then see what will be result. And the other thing we will always talk about is obviously the risk factors. So there will be a major risk factors for small for gestational age and minor risk factors. I'm not going to go through them, but you can obviously have a look. as well as we talk about placental factors. For example, people often forget about bleeding in pregnancy, especially second and third trimester, is a risk factors. It's increased risk. Even if there's no bad cause found, it's increased risk for fetal growth restriction and need a growth scan monitoring. So when we screen for fetal growth restriction, we assess all women for their historical risk factor at the initial visit, but it's important to continuously assess them because there may be new risk factor emerge, which will make you feel like this is now before you were just a nulliparous woman, but now you also have an APHs are going to organize their growth ultrasound. And obviously, accurate dating is very important, and we want to address modifying risk factor, things like smoking, healthy weight gain, good control of chronic medical condition. We say if one major factor or multiple minor factors, you will think at least 2 growth scans in the third trimester, usually between 28 and 30 and 34 and 36. But occasionally, if you identify even more risk factors, you will think then every month, 28, 32, 36. And what else I wanted to say, I'll say a few things about preeclampsia. As you all know, incidence is relatively high, 5 to 8%. Thankfully, only 0.5 we have a preterm preeclampsia. Obviously, you know the definition, so it's 140/90 and need to be confirmed or repeated measurements over several hours. If you pick up at your clinic, we're very happy for you to send this patient to us from Maternal Assessment Center, and we will do this several hours monitoring to check if this woman fits the criteria. And with preeclampsia, we have hypertension plus 1 more organ system involvement, which is in the past, everyone was very hung up on proteinuria. Yes, it's commonest, blood pressure and proteinuria, but it could be blood pressure in small baby, blood pressure and abnormal liver function test. So just important to remember with preeclampsia, just one other system. And obviously, if you have very high blood pressure, just remember it's an urgent treatment needed. Get the ambulance and get this patient across to us. What is new about preeclampsia? You probably all heard and seen about S-FLEET and PIGF ratio, our favorite PERT test. The timing we start ordering it is between 20 weeks and 36 plus 6. And the indication why we do it, we're doing it for women who considered to be at risk of preeclampsia. So, for example, a woman with hypertension pre-existing, you really would like to do the PERT for this patient because you want to know how concerned you are about her developing the preeclampsia. There could be a woman who has a clinical features of suspicious of preeclampsia, but not already confirmed. It's helpful for managing planning and decision-making with women who actually already had a preeclampsia. And it's also very helpful in a difficult situation when there's other condition which is mimicking preeclampsia. For example, women with a lupus, with nephritis, they already had proteinuria and they already have high blood pressure. Is it a preeclampsia or just a lupus nephritis? Another example will be diabetic nephropathy, worsening migraines, fatty liver, all these patients who already had some kind of other system involvement. And the PERT, especially less than 38, rule out preeclampsia within 1 week with a negative predictive value of 99.3. So it's really good. And within 4 weeks, about 94. It's based on our prognosis study. And I put like a little flow chart because a lot of people say, yeah, we heard about PERT, but how do you really read it? It depends on the gestation we performed and it depends on a number. You could see how we break it down to low, moderate, and a high risk. And you can see if you're in this high risk in red, it's a very close surveillance. We're talking about the preterm patients that will need admission. They'll likely need a corticosteroids because they're very high chance that will deliver him less than 48 hours. So it certainly is a useful test. What else is new? And again, we talked about the aspirin. That it's not as new, but the Cochrane review in 2019. We do know less than 15 weeks. Cochrane looked at less than 15, but we actually do start it before 16 weeks. Can prevent preterm preeclampsia. and it's about 60% from baseline. And it's a very good question. I think in the stage she prescribes 100. We constantly prescribe 150 and tell patients about breaking the tablets, but actually 100 is totally fine. But the only negative thing, aspirin actually can't prevent term preeclampsia. And aspirin can't prevent the fetal growth restriction unless your fetal growth restriction is a result of preterm preeclampsia. And the last few words will be around the fetal movements. Most of our hospitals will have little notes saying your baby movements matter. In terms of a recent study showing if we discuss an increased women's awareness about fetal movements and look at the pregnancy outcome, and you could see we have a firm study, My Baby Movements and Might Fetalness, really nice name, but there's no statistically significant reduction in stillbirth. One of the studies affirm say there will be increased intervention, but there's some health benefit and trend in reduction for small for gestational age. Because we know that reduced fetal movements, there's definitely association with a small for gestational age fetal growth restriction, and that's the group we really want to pick up. So if patient by mistake presented to you with reduced fetal movements, it definitely happens. I always encourage presentation, even if it's in the wrong provider place. I always auscultate for fetal heart rate because they will be very anxious. The comprehensive history is important because, again, you're looking for these other risk factors. You're looking for, is there any other risk for the stillbirth or fetal growth restriction? And I always reassure them that it's a very common presentation. About 70% women will present at least once in pregnancy with reduced fetal movement, but they absolutely need follow-up, and it's absolutely need to be done today. So they had to travel to us for their CTG. And I'll just put it because I'm from Northern Hospital. I put some useful contact as well at the end. Something you're thinking about, you need to let us know about tests, or you need advice, or you really think this woman need to come to maternity assessment center. How do you call them? How you get them quickly? And this is the end of my presentation.
Thank you, Ekaterina. That's great. So, look, thank you for emphasising the sort of decreased fetal movements, and that, a Doppler is not enough, and you really do need to have a CTG that day. So, all the hospitals feel very strongly about that. And please send your patient in. If it's the pregnancy day service is open, we all have one, and that tends to be business hours there, or else the sort of women's emergency care or emergency department. Also, that great reminder that if you do have a blood pressure of 140 or above, systolic, or 90 or above, diastolic, after taking it, 5 or 10 minutes afterwards, that they do actually need to come into the hospital for some assessment. And one of the questions was about PERT, and the PERTs are only available in hospital settings. They're not even available even for non-rebatable in general facilities. I've got a great question about adenomyosis. So if a woman has known adenomyosis, or in fact even endometriosis, is that a risk factor for small for gestational age?
We don't actually consider endometriosis, adenomyosis a risk factor. There's a little bit of discussion, but not enough evidence to say it. In fact, most of the time we will congratulate women for being pregnant because the endometriosis, adenomyosis will be better in pregnancy, and we encourage them to breastfeed as long as they can to suppress their symptoms.
Right. Another good reason to breastfeed. And the other question, I'm always amazed about the fact that the measuring has got such a low sensitivity rate. As you know, we've got increasingly women of high BMI, it's increasingly hard, but obviously having the same provider. How useful is women's subjective feeling about whether their baby is big or small if they've had another pregnancy?
Great question. In fact, I use it a lot in my practice.
So do I, yeah.
All my grandmothers, I say, how do you feel? What do you think? This is what you like. What are you measuring like? But of course, nobody done the trial to say. But I really listen to my women, and I believe this is this is a lot about if my woman say, look, I'm really worried, doctor, I would never withhold the
You'd listen
scan
to
from
it.
them.
Yeah, yeah. I remember with one of my children being sure that my baby was breech, and the doctor was saying, no, it's cephalic, it's cephalic. I said, I'm pretty sure it's breech. And sure enough, it was breech. The other thing is, I suppose, just that, I think it's really good to just tell the 164 people that are on is about the fact that growth and wellbeing scans for estimated fetal weight, really, it's hard to do after about 37 weeks, isn't it?
That's right. We do up to, we do it, last one is at 36 weeks. This is your last.
Sometimes at the women's, we sneak it to 37, around there.
Oh, you're lucky. You're lucky. Yeah.
And so really, after 36 or 37 weeks, it might be about fetal well-being, such as Dopplers and AFI,
That's right.
and that it's not about fetal growth. And the other thing that's, I think, really good to know is that distance between fetal growth scans, because it's plus or minus, is you need to do at least 2 weeks. And, often people prefer 3 weeks so that you can see whether you're on the same trajectory.
You're absolutely right. And it's in fact, they did the study looking at exactly timing, and the best interval was 3 weeks. But I find it a lot of obstetricians feel a bit anxious about 3. So if it's a high risk, we do it every 2. Like if we notice the slowing down the growth, it will be 2. But when we generally scan GDM on insulin, it will be 4 weeks. We will be comfortable with a 4 weeks interval.
Just for the many people that do shared care, which will be many people here, if there's a routine scan that needs to be done, most of the hospitals don't do routine 20 to 22 week scans. That's up to GPs to organise in the community, unless the woman's at high risk for some reason. Not high risk for growth and wellbeing, but high risk because she's had a fetal abnormality, or she's in a very low socioeconomic group, or at the women's, we also do it if there's more than 2 caesarean sections because of the risk of placenta accreta, etc. But those later scans at sort of 28 or 32 or 36 weeks are generally organised and done by the hospitals. But
That's right.
The question is that, with a sensitivity over 20%, should we all be doing routine growth and wellbeing scans on everyone?
No, the study shows that a single third trimester scan is also have very poor predictability.
No.
So no one.
Yeah. That answered my question, because I must say that sometimes I'm leaning towards that, especially with primogravitors. So I think that I don't really have any other. Somebody asked about the PERT test, but you've already discussed that, and that will be in the slides later on. Is there anything else, Ekaterina or Sarah, that you wanted to raise before we close for this evening?
I think it's Sarah here. I think it's I think watch this space in terms of placental growth factor, because I think there is a bit of evidence coming out that even in the setting of a small baby, reassuring placental growth factor can be reassurance enough to continue for more gestation. So there may be some benefit to placental growth factor later in pregnancy for determining those babies who are well but small, or the ones who are becoming more stressed. So I think there's a lot of research going on in this field, and it will be interesting to see what comes out of it. We have when it's like, it's the old saying, when you have a hammer when you have
everything's a nail.
Everything's a nail. And that's the thing. We have very, very blunt instruments in obstetrics. We've got 3 options. Wait, do a Caesar, induce. Like we have 3 options.
Yeah, it is that risk benefit. And it's interesting because next week we'll be talking about that, but next week we're talking about sort of modes of delivery. There's a really good question here about the dating scan. And I must say that, at a general practice point of view, I know obstetricians have different tools available to them. So obstetricians will often do a scan at 10 weeks and then do a NIPT and then do another scan. But what I do is I do a dating scan. As a routine person, I do a dating scan at 12 weeks. And that way the nuchal translucency can be done, unless there's a really good reason for doing it 7 weeks or something, if they've had recurrent miscarriage or something. I do a dating scan at 12 weeks and then I do the NIPT the day after if they want a NIPT. And that works very nicely. So I think that's answering that question. And I'm just getting a whole lot of thank yous to everyone. So thank you so much, and we look forward to seeing how this goes. Now, I'm just going to just see if I can share my screen, because I think I've got, yeah, got to say yeah. And I'll go back to my screen, sorry, because I've got about just one more question. I don't know where it is. I knew that this was going to happen. Sorry, I'm just going to see if I can share my screen. I'm sharing. Am I sharing? I'm not sure if I'm sharing.
You can try
Now
sharing.
it's my turn to do this. Anyway, I'm sorry. I felt like I've become so competent at this.
Sorry, it is. You can try sharing again now. Katrina
there
is
you
still
go.
sharing, so that's why.
Right. So I'm just going to go to the last slide. Thank you for those. And so this is our session conclusion. So thank you again. That was a terrific session. I learned so much. So just to remind people that we've got the second session next week about prenatal screening and non-invasive tests. So we can talk more about that, current standard of care, and also modes of delivery, what's a normal delivery, and sort of comparing, you know, elective cesarean sections at various times versus vaginal delivery, and the, you know, pros and cons of those. So that's by Associate Professor Lisa Hugh and by Vicky Carson. So I'm very much looking forward to that. You'll receive a post-session email within a week, which will include the slides and the resources. And as I said, there's some great resources at the beginning. Attendance certificates will be received within 4 to 6 weeks, as long as the Northwestern Melbourne Primary Health Network team know your CPD, and they'll also upload that to your RACGP if you're a member of the RACGP. There's a whole lot of other sessions by Northwestern Melbourne Primary Health Network that they support and run themselves, and that's on their site. And please do click into their email, and I'd love it if people looked at their latest annual report, because the stuff that's been done at the PHN over the last year has been absolutely extraordinary, and I think all my team there too. So that's absolutely wonderful. Thank you again, everybody. Everyone, enjoy your dinner if you've not had it yet, and hopefully I'll see you next week. Bye.
Thank you, Ines, for moderating. Thank you.
And thank you, everyone, to the fantastic GPs that provide all that wonderful care too. Bye-bye.
Thank you.
Thank you.